Hello again, everyone, and welcome back. Um, our next panel we have here with us will be discussing harm reduction and the drug treatment court practitioner. That's the title of the panel. We've got two amazing presenters here with us today. The first is Alejandra Garcia. She is a senior program manager for the Center of Court Innovation's National Technical Assistance Department, leading and delivering a wide range of on-site and remote technical assistance projects, including drug treatment court evaluations, opioid court implementation, statewide strategic plans, and training events. Previously, she worked as the program associate and social work intern for the center's training institute, where she co-created and implemented the strategic plan for its inaugural year, as well as collaborating with departments across the center to develop original training content. She previously interned with the New York Legal Assistance Group's Legal Health Department and has worked in a variety of roles in the area of youth development. She received her MSW from the Silver School of Social Work at NYU and her BA in Sociology and Psychology from Columbia University. We've also got with us David Lucas, who is a therapist and social work educator specializing in the areas of addiction counseling, court supervised treatment, and problem solving justice. As senior clinical advisor at the Center for Court Innovation, he consults nationally with legal system practitioners, that being judges, attorneys, and law enforcement, and clinical teams on overdose prevention, health equity, and person-centered care. Previously, he was an addiction therapist and drug court clinical lead at the Center for Addiction and Mental Health, providing support for formerly incarcerated and unstably housed patients. During those years, Dave also served as an adjunct professor at the University of Toronto, course director at York University School of Social Work, and presented internationally on drug policy and best practices for addiction care in the legal context. Before relocating to New York in 2018, he spent his last years in Toronto moonlighting at the Moss Park overdose prevention site. So Dave and Alejandra, thank you so much for coming to speak with us today. We really appreciate your time and very much look forward to hearing what you have to say. So I'll turn it over to you.
Great, thank you. Just give me one moment to share our screen. Okay. How's that, Dave? Okay, great. Thanks for bearing with us through that. So hi, everyone. Thanks so much for having us. We're here today to talk with you about bridging the gap between drug courts and harm reduction. Many thanks to Jennifer and to Justice Barnes for inviting us to be with you today. We're really excited, and we hope that you get some grounded and practical ideas to take back with you after the presentation. Okay, so today what we're going to cover over the next hour is first the origin and evolution of harm reduction as a movement, as well as its principles, practices, and scope. And this will ground us in the presentation so that we're all working from the same understanding. And then we'll talk about the intersection between harm reduction and drug courts, covering the overlap and tension we see between them. And then we'll walk through 5 key intervention points of the treatment court lifecycle, beginning with identification and going through graduation or termination. And at each step, we'll investigate how we can incorporate harm reduction by offering our own critical reflections, posing questions for you to take back to your teams, and then we'll provide a look at some opportunities for change at each intervention point. Okay. But before we get started, we want to tell you briefly about ourselves and where we're coming from. So the Center for Court Innovation is a justice reform nonprofit that's primarily based in New York City. The Center for Court Innovation works to achieve justice and equity, create safe, healthy, and thriving communities, and ultimately transform justice systems. So we do that in 3 key ways. We've created dozens of our own operating programs to test new ideas. We perform original research to determine what works and what doesn't. And then we provide technical assistance to justice reformers around the world. And Dave and I are here representing our technical assistance department, in which we do, just like Jennifer said, a range of strategic planning and training, producing publications. So we have a national perspective on what's happening with drug courts in the United States. And so you'll hear us speak from that national perspective throughout this talk. Okay, and so we just had our bios read, so I won't say too much other than just to reintroduce myself. Alejandra Garcia, I go by AJ, and what you see here is a picture of my hometown of San Francisco, California, where I was born and raised. And Dave, if you want to say hi.
Yes, thanks, AJ, and hello and good afternoon to everyone. As AJ mentioned, we're very honored to have this opportunity to speak with this esteemed audience today. I just want to send out an extra special hello to a few of my Toronto friends I see on the line. You probably thought you got rid of me, but here I am. Anyways, my name is Dave Lucas, and I'm a clinical advisor also at the Center for Court Innovation, as mentioned. I live in New York City as well, but I'm beaming in today from the very small, very cold town of Gimli, Manitoba, where I've decided to spend my winters for some reason. But apart from that, I'm just really excited to get this chance to talk about this intersection, drug courts and harm reductions. For those of you who know me, it's a very near and dear topic for me. So really excited for this opportunity. AJ?
Okay, so to begin, we wanted to tell you a bit about our motivation for this presentation and a bit about the material that we're working from. So this year, Dave and I published the paper that you see here on the right called Bridging the Gap, a Practitioner's Guide to Harm Reduction in Drug Courts. And the paper represents an effort to have drug court practitioners reflect on standard drug court practices through the vantage point of harm reduction. Now, aside from what Dave and I have learned through our work around the country, this project was also motivated by the moment. So we were and still are in the midst of several overlapping and unrelenting health crises, namely COVID-19 and the overdose crisis. We're also seeing an increase in prison deaths in some parts of the United States. And what these crises have in common is that they all show disparate outcomes, with Black people and people of color dying at higher rates. So the last year and a half has given rise to renewed conversations about institutional racism, healthcare, and criminal justice reform, altogether making the moment really ripe for reflection and tough questions about drug courts as well. So those are some of the motivations for writing this paper and presenting this material. And so now I'm going to hand it over to Dave, who's going to walk us through an introduction to harm reduction.
Great, thanks, AJ. Okay, so I certainly can't do justice to every important harm reduction flashpoint throughout history in a few minutes, but I do want to highlight some of the lineage, just so that we do have a sense of where we've been and how we got here today. So for most people, the harm reduction movement, at least in the US, begins in the 1980s in response to the HIV and AIDS epidemic. We see the first needle exchange efforts take hold as activists attempt to impede the spread of disease among injection drug users. Giving out sterile needles was illegal. And so many of the people doing this work were arrested, and often by 1988, however, there were at least 185 syringe programs around the country, but again, they were still mostly unsanctioned, unfunded, and street level operations. At this point, they were evidence-based, but largely objected to on moral grounds and still fairly politically unpopular. Prior to the 1980s, and perhaps depending on how one defines harm reduction, there are a few other moments worth highlighting. The first is the discovery of methadone as a treatment for opioid addiction, and eventually the establishment of the first methadone program in the early 70s. Methadone had been developed in Germany during the Second World War, but its capacity to treat heroin addiction wasn't discovered in the US until the 60s. Interestingly, it was Nixon who established the first federal methadone program in the 70s, and this was in response to a rise in heroin and painkiller use in the US, particularly among soldiers returning from Vietnam. As a side note, Nixon is mostly known for his anti-drug crusades, but to his credit, he did understand the importance of improving access to treatment. In fact, his crusades were more treatment focused than Reagan or even Clinton years later. So that's surprising to a lot of people. What's most notable here in terms of harm reduction, however, is that this is the first time that we hear the moral hazard critiques of substitution therapies. That is the claim that methadone treatment may simply exchange one addiction for another. But in contrast to these perspectives, there was also a growing call to decriminalize drugs in the 70s. In fact, Jimmy Carter's presidential platform included the decriminalization of at least cannabis. While these reforms never came to fruition, at least not until recently, it is notable that many of the discussions that we're having today, debate around the science and morality of methadone and needle exchange or reforming drug policy, we were having them 50 years ago. So the room has been split on these issues for quite some time. In the 1990s, at the height of drug war policing, we see the first naloxone distribution efforts take hold in Chicago, courtesy of Dan Bigg and others. In the 90s, as raves made their way from Europe to North America, so did some really important drug testing practices. But fast forward today, and we're well into the third wave of the overdose crisis, and the harm reduction movement is still fighting for political, cultural, and legal legitimacy. In recent years, we've seen the establishment of Good Samaritan laws, better access to naloxone, and we have degrees of decriminalization in parts of the US and Canada. But then you still can get arrested in other parts of the US for having sterile syringes on you. You can even get arrested for possession after surviving an overdose, because technically you have illegal drugs in your system. So all to say, for every step forward, there's often one or two steps back. Notably this year, the White House has set harm reduction as a funding and research priority, but it remains to be seen what that will include and not include. For example, the main reason that the US doesn't federally support supervised consumption sites is because of Biden-led drug policies from the past. So we'll see if those change. Okay. So just to quickly draw some borders around what harm reduction is and what it isn't, because the concept can get a bit murky and is prone to misconception. So I'm just going to run through this quickly. The most plain definition, harm reduction is focused on reducing the harms associated with drug use, sexual activity, and other behaviors that have always existed, always will, and always will carry some kind of risk. Harm reduction treats these activities as not inherently good or bad, and instead is focused on providing the information, supplies, and environments needed to engage in these things safely. It is not pro-drugs or indifferent to the real harms of addiction. It is just a very practical and research-backed set of practices aimed at improving the immediate safety for both individual and community. It can include everything from counseling, medical care, service referrals, education, and syringe disposal boxes in public bathrooms. Harm reduction is also traditionally peer-driven, which can help to make these spaces feel more inclusive, inviting, and low barrier than traditional healthcare or social service settings. Harm reduction is not technocratic, but rather a dynamic and evolving movement. It involves advocacy and activism, calls for better housing and healthcare accessibility, legal protections for marginalized groups, economic justice, and racial equity. So you can see it really encompasses a lot. And in this way, harm reduction has micro, meso, and macro aims, or in other words, very immediate and more long-term transformative goals. Harm reduction wants to enhance individual well-being, but also demand that our public health institutions become more accessible and responsive, and that our drug policies more humane and less punitive. And so just to reiterate, harm reduction is not about enabling addiction, despite some of the common kind of representations we see. It's about enabling survival and dignity as one works towards making changes in their life. It is also not anti-abstinence, which I think is really important to underscore here. It understands that for some people, abstinence is the clearest pathway to improved health, safety, and quality of life. But it also understands that for others, these improvements can be achieved through change or a reduction in one's use. While community-based harm reduction typically supports people who are actively using, The philosophy does not dissuade people from pursuing abstinence and is more so a response to the gaps and the harms that are generated by abstinence-only services. All to say, harm reduction is only opposed to abstinence when it contributes to social exclusion, but not as an individual health goal. Similarly, harm reduction is also not anti-treatment, but it does stress the importance of continuing to support people who are not interested in treatment. Harm reduction is also not indifferent to drug-related crime. In fact, a primary aim of harm reduction is to prevent people from becoming more justice involved than they already are. And lastly, we sometimes hear from skeptics that harm reductionists meet people where they're at, but then they just leave them there. And again, I think this idea comes from the belief that because harm reduction isn't directive, in other words, it doesn't tell people what to do, that it isn't directional. And so hopefully AJ and I can help clear some of that up today as we move through these different practices. Okay, so just quickly, earlier on, I listed racial equity as a harm reduction priority, but I think it's important to zoom in on this to help us understand why racial equity has become such a central focus of harm reduction. So what we have on the slide here is a very oversimplified timeline of key shifts in drug policy and the groups that were impacted the most. It's certainly not an exhaustive list, but these are arguably the most critical junctures in American, at least in American prohibitionist policy. Canadian policy does map onto this pretty closely too. Now, what hasn't always been talked about, even in the early harm reduction circles, but we have a deeper recognition of today, is that throughout history, every time a new campaign against a particular drug was being waged, or, you know, every time that there was a new campaign against a particular drug, there was also a non-white drug user being targeted at much higher rates than their white counterpart. And that is in spite of the fact that white people have always used drugs at steadily higher rates than people of color. Now, each one of these flashpoints is a complex historical moment unto itself, and I don't want to oversimplify, but if we take all of these things together over 2 centuries, we've learned that drug prohibitions have always served 2 functions. One, to try and control the moral and physical health of society in general, and 2, to help manage or restrict one or more marginalized groups within that society. Intentional or not, that's been the outcome. Now, favoring tight drug laws doesn't necessarily mean you're also in favor of racialized application of the law. However, we need to acknowledge that at every single policy turn on this list, communities of color have been harmed, policed, and jailed the most. We have no data to the contrary, so we can no longer call that kind of historical pattern an accident. And it's this reality that really undergirds the harm reduction call for major drug policy reform, especially the decriminalization and decarceration of drug users. One last quick point here, you'll note that 3 of the shifts that we might consider as being more positive are highlighted in orange. We have the end of alcohol prohibition, advent of drug courts, and the phrase that we hear all the time these days that society cannot arrest its way out of the overdose crisis. And I wish we could enjoy these developments a bit more, but even these shifts tell the same story. The end of prohibition applied only to white Americans. Drug courts have disproportionately accepted and graduated more white people. And then, of course, the current overdose crisis has recentered treatment as a more sensible response than jail, largely because of whiter communities being impacted in those first and second waves. This, of course, being in stark contrast to the much glamorized police responses we saw in the crack epidemic. Next slide. Thank you. So the last bit of history I want to draw on is this drug court timeline. And I really want to just say here that it's important that we don't view our field as unchanging or unchangeable. For a long time, drug courts didn't have its own research base or a set of best practices to adhere to. Many drug courts didn't allow the use of addiction medication. And only recently has the field started to uncover the deep racial disparities reproduced in the problem-solving courts. All to say, drug courts have had to evolve since day one, and they need to keep evolving, especially as we face new, or in some cases, recurring public health crises. So that's kind of the big table setting for today's conversation. And AJ, I'll pass it on to you.
Okay, great. So now we'll think about how harm reduction and drug courts intersect and think about where we might bridge the gap between them. So first, we want to extend our respect to those of you out there who are already doing this work by asking yourselves and your teams hard questions and trying new practices, Our goal is to honor that work that's already happening as much as possible as we try and wedge these two worlds together. So let's talk about some of the overlap and the tensions. So first off, drug court practitioners and harm reductionists have a shared interest in improving public safety, improving public health and community safety. Broadly speaking, practitioners from both worlds see treatment as more effective than jail. Both paradigms place value on addressing a person's key social health determinants. Both have had challenges achieving racially equitable outcomes, and both worlds are dealing with the same service gaps and quality issues. But obviously there are some key differences in how the two models approach the goal of reducing drug-related harm. Coerced treatment is antithetical to harm reduction, but of course is central to the drug court model. Abstinence is just one possible pathway to a better life for harm reductionists, whereas it's typically priority number one for drug courts. Drug testing participants to confirm honesty or sanctioning people for recurrences of use, again, these are core practices in drug courts and are non-starters in the realm of harm reduction. All to say that it's not easy to reconcile these two worlds, but we think there's a way to do it. And you'll see as we go through, we had to sometimes get creative and stretch our definitions in a few places. So we want to offer here some questions to keep front of mind for the rest of our presentation. And these are key overarching questions that we think will help ground us as we go through. So these are, how do our personal and societal beliefs and attitudes about drug use inform how we think about drug users? And how do those same personal and societal beliefs and attitudes inform our drug court practices? So we're proposing that these questions are a key starting place for this conversation. All right, so now we'll transition to the bulk of our presentation, which will be an explication of 5 key treatment court intervention points. For each one, we'll offer our own critical reflections on the practice, answering the question, where are we at with current practices? We'll then pose questions for drug court teams to discuss, which get at answering what steps might we take to achieve change. And then we'll present some opportunities for change that can make our work feel more transformative. And we'll cover identification and assessment, treatment planning and engagement, supervision, case management, and graduation and termination. And then I just want to note that you'll see in each of our slides some hashtags at the bottom, and those correspond to sections in our paper, Bridging the Gap. So those blue hashtags at the bottom. So we'll begin with identification and assessment. And with identification, what we're talking about is knowing our target population and effectively engaging them in our programs. And the importance of universal screening and serving high-risk, high-need participants is well established in drug court literature. So what we want to highlight here is that in the last few years, the field has recognized that treatment courts have been disproportionately serving white people. More white people are admitted, retained, and graduated than people of color, and we have the data to show that. And while that's troubling, we can understand that it's not surprising, right? It's merely an extension of what Dave was just talking about, the historically disparate outcomes that we see when it comes to policing, sentencing, and how drug treatment services are offered. But the good news is that drug courts are well positioned to address this issue if we take the necessary steps. And a lot of this could be attributed to issues of, perhaps implicit bias or gatekeeping, but we can't really know the source of the disparities if we're not looking for them. So we have to actively investigate this issue in our courts in order to address it. Who makes decisions around screening? What tools are they using? How is criminal history factored into decision-making? Are the demographics of our jail population proportionate to our treatment court population? So these are some critical questions worth asking. Okay, and for the next step, assessment. So assessment represents a really key opportunity to build trust and rapport between the person who's conducting the assessment and the participant. And we want to keep in mind here that it's the participant's first time meeting us, right? And as we know, they might have a fraught history with the healthcare or criminal justice fields, so they might be rightfully cautious with the information that they share. Assessments can be long and intrusive and ask someone to think about some of the most private parts of their life. So we want to be mindful that this experience has the potential, if not done carefully, to re-traumatize our clients and force them to share things that they don't yet feel ready or comfortable to share with us. What's more is that they might not know how to talk about their situation yet, which can often be read as withholding information or dishonesty. But we want to understand how different folks might be at different levels of understanding, and how holding on to someone's story can be a way to hold on to your power and safety and protect yourself, especially if you've been burned in the past by the systems that we represent. So in these first few interactions with participants, we want to keep in mind that in the long run, engagement, having any kind of conversation with participants that lets them know that we're here for them as a resource, that we're willing to work to build trust, is more important than the actual information that's gathered. And that's the key here, is showing the participant that you're here for them when they're ready to share, and that you have the patience and the understanding and the lack of judgment to handle that story. We also have here a key opportunity to ask upfront about a person's overdose history, and when indicated, to link them to naloxone or addiction medicine within hours of arrest to try and mitigate that overdose risk. And this is a really critical advancement in the field that we've seen. And so courts should continue to screen for overdose risk to the best of their ability. We also want to keep in mind the importance of holistic assessment that accounts for all of the various protective factors that a person brings with them. How have they navigated and survived the challenges they faced? And how can we tease out and uplift those strengths? So we want to make sure that our assessments and our reports take into account the broad range of biopsychosocial needs and strengths. Okay, so we've covered the need for us to examine our identification process and the importance of our assessment process to take into account trauma and overdose risk and become more strengths-based. And the questions that we propose that drug court teams take back with them to consider are, do we have the data when it comes to enrollment and racial disparities? And what is it telling us? Could our screening process be more inclusive? How can we make our assessment process more strengths-based and our staff trained to do so? How is trauma handled? Are participants empowered to not disclose certain information? In other words, do they know that they don't have to disclose their trauma upfront? And how is that communicated? And are we screening for overdose risk and discussing safety planning around using? And so then just some opportunities for change, and these kind of mirror those questions. So the first is that the demographics of your drug court participants match your jail population. And first interactions with participants are trauma-informed and focused on immediate risks like risk of overdose. Recognize and center existing protective factors, skills, and survivorship when it comes to assessment, and focus on engagement over information gathering. And with that, I'll pass back to Dave.
Great, thank you. Okay, so the next intervention point we have is treatment planning and engagement. And this is a big one because everything really does flow from the decisions that we make here. Now, through a harm reduction lens, the recommendation is unequivocal. We want this aspect of the work to truly feel client-driven. That means treatment plans are developed and adjusted collaboratively with a whole lot of healthy back and forth about what the goals are and how to measure success, with the client voice at the center of that. And the aim here is to find alignment between us and the participant. We don't want to just, get their acquiescence. We don't want them to sit there passively and just nodding their head. We want to hear what's worked for them in the past and what's felt safe for them in the past. And that's also because harm reduction sees people as credible messengers when it comes to all things that work in their life. And so part of that is even understanding why drug use has brought them comfort and safety. So the more we understand about that, the more we'll understand what a good treatment fit is. We also, as AJ alluded to earlier, when it comes to trying to, understand better the things that clients are not as quick to disclose, we want to avoid kind of those instincts that say, this person is not in denial, or they're not being honest with me, or they're not thinking clearly, or we know what's best. So client-driven treatment planning really means that we're starting from a place of trusting our clients, even if we're only getting part of the story. They actually have a good reason to not give us the full story in most cases. But that said, we also know that collaborative treatment planning is, even in theory, is not easy to pull off. Disagreement about what could help someone, tension between what someone wants versus what they need, the normal fears and reservations people have when considering different treatment options, even in voluntary circumstances. Clinicians wanting to feel like they're doing everything possible to help someone, even if it goes against what the person wants or what the assessment outcomes tell us. It's especially easy to have the impulse to overtreat in the midst of an overdose crisis as well. No one wants to think that they're not doing all that they can. So you take all of those very real and understandable tensions, you put this in the drug court context, and everything gets pressurized. Participants are up against it. The court basically has, in most cases, all of the leverage. Participants are facing legal consequences, whether they're brand new in the program or they've been around for a minute. And so the treatment plan is being devised with the client in the room. But if you're the client, it's quite clear that it's in your best interest to do what the court says. You want the judge or the prosecutor or maybe someone else who is skeptical about you joining the program, you want them happy. So sure, you'll do a 6-month inpatient even though they don't accept methadone. You'll do that Salvation Army or a strict AA program even if you're not religious. Whatever they want, as long as you're compliant, in your mind, you won't go to jail. Problem is, this is exactly what ends up producing some of the greatest harms in the field. Overtreating, mistreating, referring to poorly trained or culturally unsafe providers because that's what's available. This is ultimately what makes people with addictions fear, avoid, or reject treatment. And yes, it's true that many people do get through treatment after being resistant at first, but that doesn't negate the risks associated with this practice. So bottom line, hastily assembled treatment plans, especially those without the client buy-in, lead to higher rates of treatment failure, and early discharges from treatment are associated with higher rates of relapse, recidivism, and even overdose. Shoddy treatment planning also leaves an imprint on people that treatment isn't for them and it doesn't work, which of course we want to avoid at all costs. Similarly, we need to remember that treatment breakdowns are to be expected. They're very normal. Ask anyone or most people in sustained recovery how many tries it took them. The research says the same. It takes most people 5 attempts, if not more. So even if our referral was a good one, we had their buy-in, the stars aligned with bed availability, sometimes treatment just falls apart. And while this can be disappointing or even frustrating, the most important thing to do here is to focus on reestablishing safety and connection with the client. If they fear judgment or punishment, or worse yet, jail upon their return to court, what are they going to do? They're going to run, and we can't really blame them. So again, we need to take these types of challenges in stride and understand that they're very much part of the process. We want to message that to the participants too, that we still care, we are still invested in you, even if things are not moving in a linear way. And that's harm reduction, but that's also just everything we know to be true in the field of substance use and recovery as well. So there are some other things that we can do as well, or at least there are some questions that we can use as starting points for our teams. For example, how can we as system actors create more space for treatment hesitancy? Are we able to move at a different pace with some of our more ambivalent clientele, or do they have to just kind of get with the program? We can ask if our treatment partners are still the right fit for the evolving needs of our target population. Perhaps most of our participants are on medications and most of our treatment partners aren't able to work with medications. Perhaps it's time to revisit that list. For example, are we overusing inpatient treatment because that's what our primary contracted provider offers? Are we recommending one opioid medication over another simply because that's what we have access to? What about cultural fit? Are there religious aspects to the treatment we offer that isn't appropriate for some of our clients? And lastly, when we look bird's eye at those treatment plans, is there a balance between one's clinical and social or cultural needs? Are we focusing too much on reducing use as opposed to addressing some of the social determinants of health in their life? Okay, so just to quickly review, through a harm reduction lens, treatment planning should always be as collaborative as possible. It's that meet people where they're at principle that we've heard so many times. Collaborative planning means that the goals are shared, they're not imposed, the modality is agreed upon, not coerced, and the metrics of success between the clinician and the person are aligned as much as possible. That's the North Star, and it's the approach that's also backed by research as well. Importantly, this approach isn't just about being nice, though. If we could just go back to the previous slide, sorry. Because people who've been around the block can see through us just being nice. If we're not listening and we're just coercing them in a friendlier way, they're going to see through that. They're going to see us as just the same as all the other system actors. So working collaboratively, developing that therapeutic alliance and trust, it just works better. It limits harm and helps people feel like they truly own their recovery. These plans usually take a little bit longer to develop and often requires us to slow down with our clients. They take a bit more patience and negotiating, but that's the work. And I'll just say from personal experience that nothing feels better than someone heading off to treatment with some measured enthusiasm and buy-in. We really can't control what happens next, but that's okay. And we've done our bit. So some other tangible steps, we make sure we're referring to culturally safe partnerships, if not a culturally specific option. We strive to have diverse representation among our own staff and leadership. We make sure our program has an outpatient group or phase for participants who are still in the contemplative stage. I mean, that really is, to me, the most important piece for retention and to just make sure that people are moving through recovery safely. And we make sure that treatment intensity and level of care is shaped by clinical needs and recovery science, not by the seriousness or nature of one's legal charge. We also want to make sure that both new and further along participants are not just thinking about their use, but also their social and cultural needs. As I mentioned, these things are what makes life busy and fun and fulfilling after graduation. That's not just final phase stuff. We want to think about this on day one. Drug courts we have time on our sides. So let's use that time and address some of these things on day one and see how they change over time. Next slide, please. So one thing that we do know is that, somebody's going to be in our program for 1 or 2 years and they're not going to be abstinent that whole time. And they're not going to be enthusiastic the whole time. In fact, they might even be using for most of that time. So with that in mind, I think we need to also be always asking ourselves, what are we doing to make sure that our clients are using as safely as possible, if that's still the case? Well, we can do that in a few ways, and that's outsourcing, education, and access. First, we get out of the way when it comes to addiction and psychiatric medications. We partner with expert prescribers and only those that we know will treat our participants with respect and compassion. We're not trained to tell our clients to use or not use a particular medication. That one is simple, but a huge problem in the field. It's not uncommon to hear practitioners say, our program prefers Vivitrol, maybe not so much in Canada, but often in the US. But some clients want the other medications. Anyways, we can't be doing that. That's borders on drug court malpractice. Second, all of our treatment providers should know how to support our participants both in abstinence and active use. In other words, they should be fluent in the drug set and setting model and able to educate clients on the unique risks of polysubstance use. We should be also providing clients with alerts about the current drug supply. And if these conversations aren't happening, we're only doing really half of our job. And third, access. Our clients, no matter where they're at in their recovery journey, using or not, should either have or know how to access naloxone, sterile using supplies, and drug testing kits. These are life-changing, life-saving tools, and it can be sometimes difficult conversations to have, sometimes uncomfortable, but pretending that these tools don't exist just enables and increases the risk of harm, not abstinence. All right, next slide, please. Thanks. Okay, so on to supervision. And so when we think about this component of the drug court model, we have to first acknowledge that by definition, there's not really a true equivalent of this practice in harm reduction. For example, there are no curfew checks or drug testing for the sole purpose of measuring accountability or compliance. So all we can really do here is use the harm reduction lens to help us rethink about this aspect of our work in a new way. For example, the harm reduction lens forces us to examine how our drug policies shape the way we treat ongoing use in the drug court context. Put another way, how does drug prohibition inform drug court practices? Well, almost unthinkingly, abstinence has become a proxy for compliance, and drug testing has become the most important accountability tool the model has. Not maybe every court, but most courts. And while that might seem to be a little bit reductive, if it wasn't the case, our drug testing practices would be radically different. They wouldn't be observed or randomized, and contested results wouldn't lead to sanctions or termination. Drug testing would be voluntary and used to help understand if the drugs being used are contaminated or contain unexpected excipients. So what does that mean for us in a practical sense? Well, trauma-informed drug testing, which is recommended by the American Society of Addiction Medicine, perhaps offers some middle ground. This approach to testing is designed to help assess treatment adherence, but is not observed or randomized, and therefore not designed to catch people being dishonest about their use. In contrast, this approach is not predicated on the idea that our clients are untrustworthy. It is far less intrusive and can therefore help limit the re-traumatization of those with existing trauma histories, which we know makes up most of our clientele. A second process or practice at odds with harm reduction, as AJ mentioned in the introduction, is the continued use of jail as a sanction. Though less frequently used than in the past, which is a great thing, jail sanctions remain a purely enforcement-driven practice. There's no evidence base for jail sanctions, and it's not considered an effective public health strategy anywhere except in the drug court world. We have research outlining the many risks and harms, but no research showing jail sanctions are associated with improved health outcomes. As such, the harm reduction alternative here is more clear. Stop using jail and expand our list of alternatives. All courts have a range of responses at their disposal, from increased clinical support or treatment plan adjustments to homework or additional court appearances or meaningful community service. It's just a matter of expanding these. Next slide. So just to put a final point on this, the numbers are clear. Jail is associated with an increased risk of overdose as well worldwide. That means that if we're still using them as a sanction, the burden is on us to prove that we have an evidence base behind it, not just anecdotes. And so if we're continuing to do this, the burden is on us to show that it's the safest approach available to us. All that said, drug courts, of course, are still by definition concerned with accountability and measuring change. That's how folks avoid their jail sentence. So we do still have that practical consideration. And that leaves us with some important questions. What would happen if we tried to make drug testing more trauma-informed? What would that look like? What message do we reinforce when we punish people for use? Does that message align with our program's understanding of recovery? What would happen if we stopped sanctioning use entirely? And what if we were prohibited from using jail as a sanction? What else could we use? Would our program become a safer place? And so just to summarize, a more harm reduction lens has us thinking about new ways to think about compliance. If someone commits an actual crime, treat it as such. If someone is struggling to meet every obligation in a drug court, treat it like the health symptom that it is. If someone isn't following through on a commitment because of their substance use, mental health, or social instability, we should be working to address those underlying needs, not criminalizing them, even indirectly. Accordingly, as practitioners, we need to be reflecting on the ways that we might be overstepping or overusing our power when supervising participants. We want them to understand boundaries. So of course, we need to model that and make sure that we're not overstepping ours. Okay, I'll pass it on to you, AJ.
Great. So the next point in the journey of a client's progress through treatment court is case management. So case management is, of course, crucial to the overall success of our clients. But what makes our work challenging is the systems that our clients and case managers have to navigate. Our clients in the high-risk, high-need population will have had to navigate and survive years of marginalization, like community divestment, housing policies, wage inequity, over-policing, and so on. And these systems have sent messages to our clients about their worth and value, and we're in a position to potentially have the opportunity to change that narrative. So harm reduction understands systemic neglect, again, in the form of these housing policies, unemployment, so on, to be the primary issue facing drug users. So unlike in treatment courts, where we typically center the clinical treatment for substance use disorder as our main intervention and consider other services to be complementary or secondary, Harm reduction understands that if the conditions that the drug user is living under are improved through equitable access to quality services, their quality of life would drastically improve regardless of their drug using status. And a clear example of this is the housing first model, in which people in need are offered low barrier housing, regardless of their substance use or mental health or legal status. So instead of their housing being conditional upon their sobriety, housing is offered as a human right. And in addition to the material impacts that this initiative has had, providing services that are not conditional on someone's sobriety sends the message to folks that they deserve and can benefit from services at any stage in the recovery process, which can really strengthen our alliance with the client because they'll feel more able to come to us in times of need. So treatment courts should strive to work with partner agencies that provide this type of low barrier to entry services that are not conditional and can drastically improve somebody's life. To that end, we often also have really high expectations and requirements of our participants, despite being under-resourced ourselves and in our communities. So we also have to measure our clients' ability to meet the program's goals relative to what's available. And if we're overloaded as case managers, that's going to have an impact on our work. And in these cases, it's important to consider outsourcing some of that case management to other partner agencies in the community. So if you're not able to manage helping somebody apply for benefits, for example, it's important to find a different organization that can help with that, because connecting them with these types of services and benefits can have a really big impact on their lives. So some questions for teams. How can our court better account for specific health inequities? How can our court account for service gaps and our expectations of participants? Where are we going to reconcile that? What are the requirements of our partner agencies, and can participants meet them? Are we adequately staffed to provide comprehensive case management, and who might fill these gaps? And then opportunities for change. So partner with low barrier service providers, ensure that program compliance and progress is measured relative to the quality and availability of services, and develop a resource map to identify all the resources available, especially in underserved communities. Okay, and I see a question in the Q&A, so we'll circle back to that in a moment. Okay, so that brings us to the final part of the treatment court journey, which is graduation or termination. So since their inception, treatment courts have been relatively static when it comes to how success is measured. People graduate when they complete all of the program's treatment phases and meet all of its requirements, things like achieving 3 or 6 or 12 months of abstinence, paying off their fines and fees, having a house and a job, and having some kind of aftercare plan in place. And these are great, but they can be really hard feats to achieve, especially the payment of fines and fees, which often goes overlooked. That's something that Dave and I have seen over and over again. And phase advancement throughout the course of the program can also mirror some of these achievements. And while equal application of these measures can give people clarity about expectations, it also runs the risk of oversimplifying the recovery process, making it seem overly linear and one size fits all. So conversely, success within a more harm reduction oriented frame is a bit less rigid. At the individual level, success is defined by the person receiving services and reaching the goals that they've set. These goals might include a change or reduction in use, including sometimes abstinence, avoiding injury or infection, or simply surviving their next use. Several important measures of success for harm reductionists, however, are also shared by drug courts, right? So stable housing, income security, peer support. However, more can be done to prioritize and support other measures of success, like improved relationships, new connections in the community, whether it be recreational, religious, or spiritual groups, also improved physical health, and even the obtaining of documents like personal identification documents or child support payments. And uplifting these other points of progress can help our clients see all that they have to offer in addition to their sobriety. So our courts can consider having more flexible pathways towards both phase advancement and dignified program completion, even when a participant might not meet every single graduation requirement. For example, if someone's been in the program for over 18 months and their quality of life is stable and has improved, but they occasionally use substances, how can we provide this person with a non-custodial option for completion? How can we safety plan with them around overdose risk and aftercare and uplift all of the progress that they've made? So some questions for drug court teams. So the first one is, in what ways can we limit the destabilizing impact of phase demotion? So in addition to phase advancement, sometimes drug courts resort to phase demotion, which can be really destabilizing. How much does our court value other markers of success beyond abstinence? Are fines and fees prohibiting participants from graduating? How might our measures of success be more fluid and flexible? And do our graduation ceremonies place emphasis on substance use over other achievements? So these are really a starting place. And then some opportunities for change. So ensure that graduation criteria includes broader health and social outcome, again, like new hobbies and improved relationships. Explore non-custodial pathways for completion. Review existing graduation criteria against dropout and termination data. And program graduation should not be contingent on, again, the payment of fines and fees. Okay, and with that, I'll pass it over to Dave, who's gonna just wrap us up.
Thanks, AJ. So just so we have enough time for Q&A, I'll just say this, a few things as a final point here. Obviously, you can as practitioners take or leave whatever we've offered today. But I just wanted to kind of point out that some of the things that we hear doing this work at kind of a national level is that frustration levels these days are high. We also hear about participant retention levels being low. And then we also kind of just hear kind of indirectly in the way people talk about their participants, kind of like an us and them culture. And I really think that harm reduction, harm reduction isn't a solve all. It's not a silver bullet. Obviously, no one would really, I think, assert that. But I think it can help with each of these things and break down each of these issues, because it really is about relationship and connection and mutual respect. And really listening to what people's needs are and whether they're communicating them directly or indirectly, and just kind of bringing the staff and practitioner and participant in alignment. So if it feels like you're struggling with one or all of these three things, I really do think that integrating harm reduction, the principles and practices, could go a long way to address and resolve some of those tensions. So I just wanted to kind of add that as a final point. But we've got just enough time, I think, to address some questions here that we have, which are really great. The first one is about housing. AJ, did you get a chance to read that? Do you have any thoughts on that?
So I'm not sure if everyone can see it. Maybe it's unclear to me, but the question is how to get landlords on board with low barrier to housing. We've had many landlords pull units from our addiction supportive housing program due to damage, drug trafficking, etc., out of units, and now our housing stock is low. Landlords no longer want to rent to our clients. And that's a great question that I think it's a challenge. Dave, I don't know if you have any particular thoughts around that. It's something actually that we've heard recently when we kind of proposed this in New York State, that I think this is happening around New York State as well.
Yeah, I think, I mean, it's an excellent question, because I think even offering what we kind of consider harm reduction or housing first or low barrier housing, it's something that we have to do, but it doesn't come without its challenges. Often when we're housing that particular group, it's a group that hasn't maybe had housing in a long time. It's a group that doesn't necessarily Maybe their social network also hasn't had housing, so they're often housing their friends and housing their community. So that doesn't make it easy for them to necessarily kind of have control over that space. So I've seen that personally as a practitioner, the challenges around that. But I think we can kind of just impose this harm reduction framework on this, and we say, well, if the traditional view would be like, well, if they can't take care of their space, they don't get it. But that doesn't really help anybody. So I think the other way of looking at it is, what's everything we can do, given the challenges? What's everything we can do to support that person before they get their housing, when they get the housing? How can we advocate for them to keep the housing? What kind of support can we provide them, kind of just in terms of life skill education, and the value of what that housing does in terms of, just our day-to-day counseling with them? And then what can we do with our housing partners in preparation? I know this is kind of like maybe too little too late in some cases, but in preparation, when we develop these partnerships, to say, these are some of the things that can happen. This is the way we're going to try to support you as much as possible. We don't expect you to bear the brunt of all of these concerns, but we're going to try to do our best to make sure these things don't happen. Some of this is unavoidable, but that's kind of the world of harm reduction. You're just trying to look at all the different ways you can be an advocate for your participant, but also give them the skills to make sure that they hold on to things that are so important and so stabilizing, like housing. But it's a great question, and I think the best way to also address it is by having a spectrum of housing options, so that some of the housing is kind of matches the needs of different populations that you're trying to get off the streets. There was also another good question about pushback that we get when it comes to redefining success, that when we're presenting on this particular topic. AJ, do you have any thoughts on
that? Yep, sorry, I just was catching up in the chat. You said the measuring success question, right?
Yeah.
Yeah. So the question is, what's the biggest criticism you receive in presenting this approach around redefining success? And then the follow-up says, do you have any recommendations for measuring success tools? And actually, that is the biggest question that we get around this recommendation, is how do we measure these things? And so Dave and I are doing some work around opioid courts, which are much less defined. That's a model that's new. And so we've put our heads together around different types of checklists that folks could use just as a way to open a conversation with participants around these different things that I was talking about, around improved relationships, physical health, things like that. But this is going to be a situation that's a lot less rigid and harder to measure than traditional things like months of abstinence that we know through drug testing and things like that. So Dave, I don't know if you have anything else to add about that, but
I would just add that part of this has to be kind of addressed indirectly by shifting the paradigm away from just kind of the inherent criminality of drug use. And if we start to see, that, and this might seem counterintuitive compared to everything else we said today, but in the drug courts are also about recidivism, about criminal activity. And if somebody is not negatively affecting community safety, and they're not involved in the justice system, but they're still using here and there, I mean, drug court's kind of done its job. Drug courts are not just in charge of making the world sober, right? The drug courts are also are about making individuals and the community both safer. And if you can make the point in a clear-cut way, no new charges, the person's been complying and doing their best in every other way, I think it's easier to make a case. But the challenge in a lot of contexts is that drug use itself is so still stigmatized and so heavily criminalized in the language used, that it can be hard to think about success in as existing alongside ongoing use. So I think it's not always going to be easy to do this, but slowly, as you develop cases, you see certain people do really, really well and make important improvements in their life, but they not necessarily completely abstinent. you want to hold them up as kind of examples and say, like, it can be done. And this is a success for us too, not just the participant, but we've done a really good job with a person who might not be absent for the rest of their life, but they're not going to be in jail. They're not going to be on the streets. So we want those as examples because that's good for us too. I think it shows that we know how to support people, even if they can't meet certain strict requirements, but we need those kind of case studies to kind of prop up. I hope that hope that helps. I think it's going to be a slow process in some cases, though.
And just wanted to add one quick thing, which is that something that Dave and I talk about often is how the early months of the COVID-19 pandemic really had drug courts, at least in the United States, really rethink drug testing in particular, and how they might move folks through phases and graduate people while they weren't able to rely on drug testing as a tool. And so they often kind of relied on their clinical intuition or their alliance with participants to make those decisions. So we would also encourage courts to think about how they might gain some of those or use some of those lessons learned from those days when you didn't have all your traditional tools in the toolbox.
Yeah, and absolutely. And I would just add to that anybody that's been in this business for a while, you tend to know when your clients are using. And even if they do slip in a use here and there, and maybe that goes undetected, these things tend to kind of work themselves out. It's not the ideal, but what we want to focus on just as much is, as AJ said, have we built that trust? So that we're not so concerned about whether or not somebody is disclosing honestly, but have we as practitioners, as system actors, created such a safe space that disclosing use actually is easy? Because if I have a client and that this person doesn't want to tell me that they've used, well, that's some of their stuff, but it's also some of my stuff. Maybe I've propped them up too much for their long extended period of abstinence to the point where they think I won't feel the same way about them if they've used. So it's a give and take, and I think it's a clinical issue, but I think it's also a cultural issue from all practitioners in the court, and we want to make sure that we are propping up our participants for all of their small successes, not just for what's showing up in their drug test. And I think over time we'll see less and less importance placed on what comes back in the drug test in terms of it being kind of the primary measure of recovery and improved health. That's my North Star, at least. Yeah.
So I think we're at time, but there is just one more question. Maybe we can
go for it.
Quickly address. Yeah. Okay, so there's one more question. It's, can you provide more information on trauma-informed drug testing? What would that look like? And I know Dave has given that a lot of thought. If you want to answer that one, Dave.
Well, I think the primary is first off, try to get away from observed testing. So we're seeing more oral swabs being used now to try to test. There's some different limitations to that, but again, there's nothing's going to be perfect. Even urine testing isn't perfect. So I think the best thing to do is to first think about, what are our medical professionals saying about the potential to re-traumatize by somebody having observed drug testing. People who have experienced sexual violence and people with PTSD have studies have shown that observed drug testing can be re-traumatizing. So anything we can do to move away from observed testing, put a little bit more trust into the participant, and just kind of, again, shift the culture and the paradigm away from this idea that we're catching participants and just use it as a measure of like, this helps. Hopefully this is used in a way that helps them as much as us kind of gauge how things are moving along. Some participants are going to want drug testing. I've had drug test participants tell me that it's helpful for them. So let's just make sure that it's only helpful and not inadvertently harmful as well. But I think moving on to something like oral swabs, is probably less demeaning than having somebody watch you, provide a urine screen.
Great. Well, thank you, everyone. Thanks for having us.
Thank you to both of you. If I could just take a second, it's been really eye-opening and inspirational as well to listen to the work that you've been doing and the presentation. I have to say, from my perspective, I'm a provincial crown, so the equivalent in the States to an ADA, and it's it really turned my mind to how much more we can work in collaboration with our community partners and the other members in the justice system, part of our team. Because I think you made this point, Dave, where you said that the clients can really see through us. And that really stuck with me because if we're not being genuine in our intentions and how we, if we're not being genuinely kind towards them as opposed to having an ulterior motive, they could see through that very easily. So that was a really big take home for me. And thank you for that. It's been really great, like I said, and I'm going to watch this on repeat a few times. So thank you very much for your time. And if I could just close out for the day, thanks to everybody for attending. Thank you to all of our panelists, moderators. Everyone today it's been great. For people who are able to, we hope that you join us again tomorrow for day 3 of our first annual conference. And it may be helpful if you delete the link in your inbox for day 2 and probably day 1 so that you don't get confused about which link to push for tomorrow. That would be really helpful. One of the questions that we have had pop up is, when are these panels or presentations going to go live? Once we figure out the logistics of that and get permissions that we need to get, we're looking at about maybe late next week or early the week after. We'll be able to post them on our website, which is justicetreatment.org. And we hope to see you tomorrow. This has been great. We really appreciate the feedback, and we hope to see you tomorrow. Have a great night. Be well, everybody. Bye-bye. Erin, I can push stop recording, right?
Yeah, go ahead.
Okay, thanks.